Good morning. This is Dr. Andrew Armstrong at Duke University. I'm going to be presenting a presentation on prostate cancer this morning to you with a particular focus on biomarkers. And this lecture will be on prognostic, predictive, and surrogate factors, including biomarkers in men with castration-resistant prostate cancer, so the more lethal variant of prostate cancer. I am an associate professor at the Duke Cancer Institute in the Department of Medicine. I'm a medical oncologist. I treat patients with advanced prostate cancer. I'm also a clinical researcher with a focus on circulating tumor cell biology, experimental therapeutics in prostate cancer, and I conduct a number of clinical trials in the disease. So let's get going. The outline of this talk will be the current state of prognostic and predictive factors and biomarkers in men with castration-resistant disease as of the current date, 2013. We're going to talk about surrogates for drug development in prostate cancer. We're going to talk about the working group 2 criteria and some of the changes that we might expect with the newer criteria emerging, and we're going to focus on some future directions. I want to emphasize that for this lab roots presentation, all questions are welcome. I'm going to hold questions to the end, but please, when you're typing in your question, please do that in real time so that by the end we'll have a list of questions that I can go through. So the clinical states of prostate cancer in 2008 were really defined by Howard Scher and colleagues, and really categorized prostate cancer as localized, PSA recurrent, metastatic hormone sensitive, metastatic castration resistant, and the non-metastatic setting as well. Lethal prostate cancer really is illustrated by the red boxes here in metastatic castration-resistant disease, where the death rate from prostate cancer really outpaces the death from comorbidities. However, in 2013, we have a number of newly approved treatments. We have a better understanding of molecular biology and clinical prognostic phenotypes in prostate cancer. And so the disease state model in 2013, while very similar to the prior model, now illustrates the importance of prior therapies in dictating the next best therapy for a patient. And so first-line therapy, second-line therapy, third-line therapy in 2004 was really, a goal, but now we actually have this plethora of therapies that I'll cover a little bit. The goals moving forward, however, are to really model our disease after many of the other oncologic diseases, such as breast cancer and lung cancer, where we have a molecular taxonomy for adenocarcinomas. And we can use that to both risk stratify, but also to predict for therapies that may be of benefit directly to our patients in clinic. And as you can see in this cartoon, disease burden really increases over this disease state to more treatment refractory settings. So there are multiple treatment options for men with prostate cancer now, beyond surgery and radiation and hormonal standard therapy that induces castration. We have a number of treatment options available to men with metastatic disease that is failed hormonal therapy. So the definition of castration resistance is progression in the face of a low level of testosterone, typically 50 nanograms per deciliter. And the treatment options for men with metastatic disease are now based on whether a patient has symptoms or not, the presence of visceral disease. It includes immunotherapy with CYP-T, abiraterone, enzalutamide are both moving and positioning themselves to be sandwiched around immunotherapy in the pre-docetaxel setting. Docetaxel is largely being used after these hormonal and immunotherapies. And we now have a number of agents approved in the post-docetaxel setting, including these same hormonal therapies, cabazitaxel and radium-223, our most recently approved alpha emitter. So I'm going to not focus on these therapies directly, but really on understanding the heterogeneity of the disease biology and how we can use biomarkers to help select patients for these therapies. One of the problems in prostate cancer is that castration-resistant disease involves many mechanisms of progression, some of which involve mechanisms that are independent of the AR or indirectly involve the AR. And these can be shown broadly here that involve immunologic escape, oncogenic proliferative signals that act independent of the AR, survival signals that involve tumor suppressor loss, Bone microenvironment signals, prostate cancer commonly spreads to bone, and the bone fosters survival of these tumors and their growth and resistance to therapies. There's a number of other kind of terms called stemness or epithelial to mesenchymal transition pathways, as well as DNA repair, that are also important that I lumped in the bottom there. But the androgen receptor remains the #1 target for prostate cancer, and there's a lot of overlap with these AR-independent mechanisms. The mechanisms of AR-dependent castration-resistant growth involve AR amplification, overexpression, gene mutations such as activating point mutations, mRNA splice or deletion variants, glucocorticoid receptor upregulation, which can hijack the transcriptome of the AR, as well as emerging data on the ectopic androgen production by prostates, particularly castration-resistant prostate cancer, that can really turn into an endocrine or autocrine organ, manufacturing its own endocrine ligands for use by an amplified receptor. There are also a number of AR-dependent fusion proteins, and many of the top purple signals can overlap and talk to the AR, including the retinoblastoma family, PARP, ERG pathways, as well as a number of others. I'm not going to spend a lot of time on molecular biology, but rather the biomarkers that we might use in the clinic to really identify patients who have these diverse mechanisms of progression. The good news in the past few years is that we have 6 new drugs showing real clinical benefit. Docetaxel has improved survival. Provenge or Sipuleucel-T immunotherapy has improved survival in asymptomatic patients. The Cougar 301 and 302 trials have positioned abiraterone as a drug with real clinical benefit, both in the pre- and post-docetaxel settings. Denosumab has prevented skeletal-related events to a greater degree than we've had previously without an improvement in survival. Radium-223 has extended survival for the most symptomatic patients with bone-predominant metastatic disease. And then enzalutamide was positive and reported last year in the AFFIRM trial in the post-docetaxel setting, with the PREVAIL trial anticipated in the next few weeks. So we have major questions with new agents, the appropriate sequencing over these therapies, the use of combinations versus single agent therapies that are facing many other disease types, and then patient selection. Patient and tumor factors, i.e. biomarkers, can help us maximize the benefit to our individual patient with castration-resistant disease, and then minimize the harm of unnecessary or ineffective therapies, as well as the burden of the cost of these very expensive drugs that may or may not work in certain patients. And so drug development in castration-resistant disease, there are many impediments, although we've had success. There has generally been a lack of the understanding of clinical CRPC progression of the biology and these biomarkers in the clinic. Metastatic biopsies are difficult to obtain, and linking these to event outcomes is really a goal of many current ongoing research studies. These men are typically older, in their 60s and 70s, with competing causes of cardiovascular mortality and other mortality. There's been a lack of many surrogates for survival that the FDA has accepted for approval. And as I just showed you, there's great disease heterogeneity. Just because we call one disease prostate cancer doesn't mean it has the same underlying molecular biology. And we've seen that from high throughput genomic studies of metastatic prostate cancer. Essentially, each tumor in each patient is really different genetically. And so the key remaining questions are, how do we make sense of early phase trials to move them forward? How do we use biomarkers to maximize benefit? So let's start with a few definitions. This is a broad lecture on biomarkers, especially as they relate to prostate cancer. So a biomarker is defined as a characteristic that is objectively measured and evaluated as an indicator of normal or abnormal pathogenic processes or a response to an intervention. And these can include survey results, blood tests, genetic biomarkers, urine tests. Radiographic imaging is certainly a biomarker. A pain score is a biomarker if it's quantitative and objectively measured. And so biomarker here is a broad term. I'm going to talk mostly about several types of biomarkers, but there are many types of biomarkers. These include prognostic, predictive, surrogate, pharmacodynamic, pharmacokinetic biomarkers, mechanistic type biomarkers. Prognostic biomarkers, however, are a particular type, and these are disease and host characteristics that estimate the chance of some natural history events, such as death or progression in the sense of cancer, most commonly, or recurrence. Just to give you an example of this on this slide would be PSA. PSA is a prognostic factor across the disease continuum from localized disease to castration-resistant disease. The higher the PSA, the worse the prognosis in many cases. But predictive factors are really a different criteria. These are also disease or host characteristics, but now they estimate the chance of specific improvements with a particular treatment. In breast cancer, for example, HER2 oncoprotein expression, overexpression, really predicts for the benefit of HER2-directed therapy. And I'm going to talk about predictive factors in prostate cancer next. So each of these factors can be used to group patients for trials or in the clinic into relatively homogeneous subsets defined by biology or clinical phenotype, and can optimize the delivery of care depending on the context of use. So here is a table of the validated prognostic biomarkers in castration-resistant disease. And this listing is based on existing nomograms and multivariate models. Not all nomograms measured the same things at the same time, so we don't have an all-encompassing nomogram that has everything in them. But these biomarkers that I display here have been independently validated in multiple data sets, and they include some very obvious prognostic factors such as pain and the functional status of a patient, certain blood tests such as lactate dehydrogenase, the PSA level and the PSA kinetics, your circulating tumor cell count in certain settings, the degree of anemia, the pattern of spread, particularly visceral disease being a poor prognostic finding, measures of inflammation such as C-reactive protein and albumin, measures of bone turnover such as alkaline phosphatase and urine N-telepeptides. Even the Gleason score is an important one. Others are listed here as well with some controversy. And as well, after you start a treatment, whether it's a hormonal treatment or chemotherapy, if these biomarkers change or improve, they are also prognostic. So if your PSA goes down, you may live longer. Pain improvement, quality of life improvements are all linked and associated with better outcomes. That doesn't make them predictive unless they're tied to a specific therapy, because any therapy that improves these will result in better outcomes. Progression-free survival, changes in circulating tumor cell enumeration are also prognostic, as are bone turnover markers. For immunologic correlates, we also have immune response. So ELISpot assays have been associated with improved outcomes. And there is a frequent misuse of the word predictive in the literature. I'm going to highlight on this slide here a comparison of different prognostic models. So when you're in the clinic, which prognostic models do you use treating men with metastatic castration-resistant disease? These are some of the three available, although more are emerging as the trials are updated and published. But these trials are based on older data. The TAX327 study, which I've been a part of, is probably the most contemporary of these three. This involved 1,006 patients and was able to prognosticate up to 5 years and had a relatively good predictive ability. It incorporated 10 or 11 different prognostic factors and was really validated within a pivotal docetaxel trial. So really contemporary use is present for the TAX327 nomogram. That is to say, until we have all these new treatments. And so as our new treatments kind of push chemotherapy back a little bit, and we have different settings where we want to prognosticate, other nomograms and prognostic models will become important in different settings. And I would just put in a plug for, we have developed an iPhone app for the TAX327 nomogram. You can find this on the App Store. It just was released about 2 weeks ago. And that can help you in the clinic kind of estimate for a given patient their prognosis in the pre-docetaxel setting, as well as in another nomogram that we validated in the post-docetaxel setting. And this is just an example of our post-docetaxel nomogram, and this is taken right from the Clinical Cancer Research paper several years ago, showing how we can take many different factors and put them together on a single patient and estimate their 6 and 12 and 24 month survival natural history. Of course, this natural history can be improved now that we have more and active treatments that can extend that survival, but it gives you a sense for what to tell a patient in the clinic who may want to know whether to pursue further therapy based on their current prognosis should they not receive more therapies. And this is an example of a prognostic factor. PSA doubling time, or the rate of rise of the PSA, is very important across the disease setting in castration-resistant disease and localized disease, as well as biochemical recurrent disease. And you can see here, going from white to red, there's a very important change, as you can see, and I'm drawing here. As your PSA doubling time lengthens, survival time improves. And that is a real independent validated prognostic factor, which is incorporated into our models. So there's some pros and cons of nomograms. Obviously, they can be helpful for trial stratification, if you want to ensure balance between two arms. They have pretty good prognostic ability, although by the time they get published, they're often out of date. But they can identify high and low risk groups of patients. They can facilitate communication in the clinic with historic caveats. But they have some limitations. They often are based on convenience samples. The trials that use them and measured these variables often lack other variables. They give some incorrect information about 30% of the time, so they're imperfect. And they do have some missing data, importantly, on the disease heterogeneity and underlying oncogenic signatures. Mutations, for example, are not incorporated into these nomograms, and that's the hope moving forward. Here's another example of a prognostic factor that is useful both before and after docetaxel, is the measurement of circulating tumor cells. And this is a simple blood test, much like a PSA, but instead of measuring a protein that's made by tumors, such as PSA, this is actually measuring the tumor cells themselves in the bloodstream. And you can imagine that if you have a high number of circulating tumor cells, you have a poor prognosis of around 11 months in men with metastatic disease in the pre-docetaxel setting who go on to receive docetaxel. And likewise, if you have a low circulating tumor cell count, less than 5, you have an improved prognosis of about 1.5 to 2 years. But most importantly, these tumor cells can be altered in the course of effective therapy. So going from the green line to the orange line would indicate progression of a patient despite docetaxel and a poor prognosis. And likewise, going from the red line to the blue line can indicate an improved prognosis, in which you can update a patient on their prognosis as their circulating tumor cells decline and provide some reason for optimism during a course of therapy. There's a number of ways to use prognostic models. You can use nomograms, which include 10 or 11 or 12 or even more variables, and that's why we developed an app for this. Or you can be more simplistic about it and lump the most important risk factors into what's called a risk group, and we've published on this in European Journal of Cancer. There's 4 major risk factors in castration-resistant disease, at least in our data set, that include the presence of important pain requiring narcotic analgesia, the presence of liver, particularly visceral metastases, the development of new bone lesions prior to therapy, and progressive anemia. And when you take these 4 risk factors, you can create risk groups, much like the kidney cancer risk groups that we're all familiar with. Good risk castration-resistant disease has 0 to 1 risk factors, and you can see here a survival that's around 2 years, much like the Sepulis LT type patient who is asymptomatic and has no visceral disease. And a poor risk patient has 3 or 4 of these risk factors, and this is much like the Alsimca trial data that led to the approval of radium. These patients are poor risk, they have pain, they have new bone lesions, they have a poor survival. This is simply reporting on natural history. And these risk groups can be used for clinical trials. They can also be useful for busy clinicians who can't remember all the nomogram factors and can simply estimate just by looking at a patient with some very easy to remember clinical risk factors. I want to show this. This is a paper that we have in Press in European Urology, illustrating the importance of visceral metastases in dictating survival in this castration-resistant setting. And this shows the pattern of spread ranging from node-only disease right here with a survival in excess of 2 years to patients with liver metastases. And this group of patients is some of the most poor prognostic patients in which a survival of under 1 year is expected and better treatments are needed. So the pattern of spread really dictates survival in many patients Interestingly, in this study, the patients with bone-only disease did nearly as well as the patients with lymph node-only disease. And patients with lung metastases did much better than patients with liver metastases, showing that the pattern of visceral spread is even important here. And the importance of visceral disease is important because many drugs don't work as well in the presence of visceral disease. However, they still may work. So here's an example from a poster at ASCO this past year showing that enzalutamide does work in both patients with lung and liver metastases, but the overall survival of these patients is much shorter than you might expect, as you can see here, only 9 months with enzalutamide treatment in the presence of liver metastases, while lung metastases patients did a lot better. And there was a benefit with enzalutamide in this setting, but we really need better therapies that can address the visceral spread of cancer. So the application of these prognostic models to patient management, obviously we talked about creating homogeneous clinical populations for our trials, but also to help at the bedside with prognostication. We're trying to develop more easy-to-use nomograms, such as these apps that I mentioned, as well as more updated models based on contemporary series of treated patients. Let's touch base now on predictive factors. Predictive factors are really quite easy to describe. In prostate cancer, there are none yet. And one of the areas of research that I spend a lot of time thinking about, and many in our field do, is trying to develop predictive biologic factors that can lead to better therapies, specifically for men with these factors. As I mentioned, there are many phenotypes of prostate cancer. There are many genotypes as well. And the qualification requirements with the FDA for a biomarker are very intense and often just as intense as the phase 3 trial of these drugs. As we can see, many new drugs in oncology are getting approved with companion diagnostics such as HER2 testing or RAS testing or EGFR testing for mutations. And the consideration for validation, analytic validation, clinical validation is very intense to make sure you have a validated test that has been qualified through external validation, through prospective trials across different mechanisms, ideally. And just as an example of some predictive biomarkers that have shown some success in oncology, breast cancer leads the way, certainly with HER2, estrogen, progesterone receptor, which are clearly linked to better outcomes with certain drugs. Lung adenocarcinoma is becoming quite a heterogeneous disease with EGFR-defined adenocarcinoma, ALK fusions, very much histology-dependent predictive biomarkers with certain chemotherapy agents. Colorectal cancer and RAS mutations and the lack of benefit of certain drugs. Hematologic malignancies have long understood the value of predictive biomarkers for rituximab and Gleevec for the Philadelphia chromosome. Gastric cancer has recently shown some data with HER2. And renal cell carcinoma, a GU malignancy, has had several predictive factors such as LDH predicting for the benefit of an mTOR inhibitor. Histology is a simple predictive factor for the benefit of cytokine therapy. Some potential predictive biomarkers in castration-resistant disease, these are challenging, but clearly there's a sense that AR activation or AR mutations may predict for enzalutamide resistance or sensitivity. There's been a recent study that androgen precursor levels actually are not a predictor for abiraterone sensitivity. Patients with low androgen levels still seem to benefit, at least in the serum, seem to benefit from abiraterone, so that is not a predictor. There's a number of drugs targeting the PI3 kinase pathway and looking for pathway activation as a predictor. Recent data on microtubular mutations and measuring these in circulating tumor cells may be a taxane sensitivity predictor. Measures of high alkaline phosphatase seem to be a predictor for radium, but that requires validation. There are some 1% of prostate cancers have RAS mutations. There are ongoing studies looking at DNA repair inhibitors, such as PARP inhibitors, particularly in the context of these ERG fusions that can cause DNA repair defects. The intact retinoblastoma protein may predict for cell cycle inhibitors. Another recent one that was just published a few weeks ago is Gleason score. So high Gleason score seemed to be predictive for the benefit with docetaxel chemotherapy, which was interesting, and that was published in European Urology. There are a number of others, including the neuroendocrine histology, in which aurora kinase has been amplified, and aurora kinase inhibitors are under trials for these rare histologies, but emerging and important histologies. Another simple predictor could be PSA, so low disease burden may be a predictor for the benefit of immunotherapy, and we've seen the quartiles plots of Sipulus-LT showing a greater impact on survival in men with a low PSA, particularly under 20. So that's kind of a summary there, and the goal is to take these predictors and validate them in clinical trials and to move from a kind of random drug selection with a random patient population that's not enriched to a more enriched setting where we can exploit tumor vulnerabilities, use synthetic lethal strategies. We can reduce oncogene addiction, such as through the AR. We can reduce ligands that are important in patients who are making ligands, or we can block androgen receptor where it's amplified. And so exploiting the tumor, specifically where the Achilles heel exists in a given tumor, is the emerging mantra for prostate cancer going forward. I'm going to put in a plug here for circulating tumor cells or circulating plasma DNA, ways to predict for drug benefit and mutations and high throughput sequencing using blood-based tests, essentially a liquid biopsy. And both plasma DNA and circulating tumor cells have shown important prognostic roles, but more importantly, they offer a window into the biology of the cancer where we may be able to get to these predictive factors. Instead of sticking needles into bones and tumors, which you can't do very often, CTCs allow you a longitudinal and minimally invasive assessment of tumor biology, provided they can be measured. So this liquid biopsy, what can you see in the circulating tumor cell? And here's some examples of some emerging data just from the last few years. We've shown that circulating tumor cells can express both epithelial here and mesenchymal proteins, E and N cadherin, suggesting that EMT is important in castration-resistant disease. You can see that P10 is important. Its loss can be assessed in circulating tumor cells. You can see the importance of AR amplification in certain prostate cancer patients. And so, and then down here at the bottom, you can do whole genome approaches in circulating tumor cells, illustrating that things like androgen receptor can be ascertained just through the blood with high throughput techniques, including mutational analysis. So this is really one opportunity to get at tumor biology in a non-invasive way. There are limitations. The current assay often doesn't lead to circulating tumor cells being detectable, even in the presence of metastatic disease in about a third to 40% of men. It's very dependent on a single biomarker, EpCAM, for the capture of these cells. Often circulating tumor cells, at least using the current method, is not optimally detecting cells until patients are really treatment refractory and in the post-docetaxel setting. We found that EpCAM loss is correlated with EMT and the expression of these stemness markers, and we're actively working, and the field is actively working on developing next generation circulating tumor cell platforms that may be able to get a range of CTC phenotypes and different types of CTCs that are circulating in the blood of these patients. So in the last few minutes, I want to spend some time talking about surrogate biomarkers. This is an important area for drug development. For those of you who do research in prostate cancer, having a surrogate biomarker is an important step in ensuring your drug's success. So for those of you in industry and in academia, surrogate biomarkers have really been a way to accelerate drug development and getting your agent to patients who will benefit earlier. Statistically, surrogate biomarkers are defined by several criteria. One is by Ross Prentice, and there's the reference in 1989 now, in which treatment has to change an endpoint. So it has to improve your definitive endpoint, such as survival. Let's say you have a clinical trial that improves survival. And now you have a surrogate that you want to test, which is an intermediate variable, such as PSA change or progression-free survival. The full effect of the treatment on survival needs to be explained through the effect of treatment on the surrogate. And you can quantify this by a number of methods, such as the PTE statistical method or likelihood ratio. You need to look at this across many different trials, ideally across different mechanisms. And you can see here simplistically that treatment needs to alter the surrogate, and the surrogate needs to be highly associated with survival. But as we know, there are many ways around this association, that a surrogate might be associated with survival, but the treatment doesn't change that surrogate, or that treatment may actually reduce survival independent of the surrogate through drug toxicity, for example. So evaluating the association of treatment with survival is very important and can be done statistically across many studies and within studies. So again, a simplistic discussion of surrogate biomarkers in castration-resistant disease is that none to date are definitive across all trials. Overall survival remains the gold standard for FDA approval and to determine whether a drug is beneficial in a clinical phase 3 trial. That doesn't mean that other surrogates, are useless. That means that we just haven't proven them yet. Surrogate biomarkers do depend on the mechanism of action of the drug, and I'll spend a few minutes on that with the next few slides. Some of the surrogates that have been evaluated and are under evaluation right now include very simple things such as the PSA going down and the degree of PSA decline, having a pain response or a radiographic response, delaying the time a patient has before their tumor progresses, having a drop in your circulating tumor cell count or time to circulating tumor cell progression are all biomarkers that are under evaluation as surrogate endpoints. And the CTC data and the PFS data are really the farthest along in their potential to be surrogates. However, you can get a drug approved by the FDA by showing clinical benefit without having to worry about survival or surrogates. The FDA has approved, for example, mitoxantrone based on durable pain palliation. There are drugs that we use commonly, zoledronic acid, denosumab, that can prevent skeletal-related events that are felt to be clinically relevant. And there are trials ongoing right now, such as with cabozantinib, that are evaluating durable pain palliation as a real clinically meaningful endpoint. Of course, we need to do the studies to really prove that these endpoints can lead to improved survival, but they may be endpoints in and of themselves. Let's talk about progression-free survival. So progression-free survival is variably defined in prostate cancer. Some progression-free survival uses PSA, some doesn't. Some uses just radiographic or clinical progression. You can see here from the curves from Susan Hallaby's work that a patient who is progression-free at 3 months has a better survival long-term of 20 months versus a patient who's already progressed 3 months into treatment has a worse survival of about 7 months. And the hazard ratio is highly significant. And prostate cancer patients with castration-resistant disease typically develop PSA progression before they develop bone progression and before they develop pain progression. And however, there are some disconnections between those in some cases. However, there are many diseases where the PSA progression does not associate very well with survival. And largely, PSA has been dropped from the criteria in clinical trials for determining whether a patient's benefiting from a drug. For example, we clearly know that abiraterone and enzalutamide do drop your PSA, but that the PSAs can drift upwards during the course of therapy for many, many months before radiographic or clinical progression occurs. We also understand that there are issues with PSA declines in chemotherapy, such that many cytotoxic agents can benefit a patient even in the absence of a robust PSA drop, and that the overall survival improvements can be seen even with lesser degrees of PSA decline. So let's talk, this is a complicated slide, but I want to spend a few minutes on this. This is a graph of progression-free survival, hazard ratios on the x-axis, and overall survival hazard ratios on the y-axis for all of our phase 3 trials, and including some randomized phase 2 trials as well, to illustrate the value of surrogacy and progression-free survival. So in the blue area that I've color-coded, these are drugs that are approved or emerging that have really had positive studies in which you can see, for example, cabazitaxel, abiraterone, all showing improvements in both progression-free survival and overall survival. However, there's some real differences here. You see Sapula-Cell-T out here, ProstVac right here, where there were improvements in overall survival, but not really improvements in progression-free survival. So immunologic therapies, at least using older definitions of progression-free survival, may not change that short-term natural history, but may result in a clinically important improvement in the natural history in terms of survival. And the opposite of that would be anti-angiogenic therapy, at least VEGF-targeted therapy. You can see up here, VEGF-TRAP, Avastin, Sutent, all resulted in improvements in progression-free survival, but no improvements in survival, and these drugs are not approved. And so just because a drug delays progression-free survival by a little bit doesn't mean that it will improve survival. This could be because of excess toxicity. It could be because of other reasons, and I'll explain that in a minute. One of the issues is that we might be misclassifying progression, and this is taken into account with the new working group guidelines, and this is a great case to illustrate that. So when we get a bone scan in a patient with metastatic prostate cancer, we often see a few lesions, such as this patient right here, who's got a bone lesion in the sternum, PSA of 200, castration-resistant disease. This patient goes on to active therapy, let's say abiraterone, and 12 weeks later he comes in, his PSA is down to 12, and he has a new lesion, as you can see on his bone scan right there. This patient feels great. There's no sense of rib pain. What to do about this? Is this progression? Is this flare? Is this healing? Well, bone scans really image osteoblast activity. They're an indirect tumor biomarker. Osteoblasts heal in the presence of fractures. Osteoblasts produce more uptake of the technetium in the presence of healing. And so osteoblastic activity can be both a healing reaction or a flare or a progression. And in this case, the patient stayed on the drug and his PSA still declining 12 weeks later, and he still has just the same single new lesion. And this is a great example of flare or healing, in which in the old days we might have taken the patient off at week 12, and he never would have received the great benefit of some of these drugs. And this patient went on for several years to remain on abiraterone. Flares have been commonly seen with both enzalutamide and abiraterone. They are emerging, and essentially the guidelines have now changed for interpreting bone scans in the face of these active therapies. So instead of taking a patient off a drug for a single new lesion or a new lesion seen at that first assessment, flare usually happens in the first 4 months. And so getting an additional bone scan, what's called a confirmatory bone scan, is recommended. And if you see additional new lesions over time beyond that first assessment at 12 weeks, or whenever you're getting that initial bone scan, for example, 8 weeks, if you develop progression in the face of an initial bone lesion, that becomes real progression. If new bone lesions are not developing over time, that's felt to be flare. And of course, you have to put this in the context of the patient. So if you have a PSA going down, that may be more of a sign of bone scan flare. Bone turnover markers such as alk-phos may go down with flare. You may also see soft tissue disease. And so you have to put this in the context of the patient and their pain and other biomarkers. But generally, flare is defined as new bone lesions or flare or brightness of existing lesions in the face of an otherwise clinically responding patient. Some of my thoughts on progression-free survival, and this becomes important with many of the new drugs that are in trials right now, is that improvements in progression-free survival may be delayed with certain immunotherapies that really take a prolonged time to essentially kick in. And so the benefits of drugs like immunotherapies may really occur beyond when a protocol defines progression. And they may slow the rate of rise or growth rate of the tumor in a way where progression-free survival just can't capture that using the current definitions. And there are some modified definitions of PFS that account for immunologic radiographic changes. Cytotoxic therapies produce a pretty linear relationship between PFS and OS. So cytotoxic drugs like Docetaxel and Cabazitaxel have a very similar hazard ratio for these endpoints. So if you're looking and screening a cytotoxic therapy, a progression-free survival improvement is a reasonable surrogate, most likely, for overall survival. Anti-angiogenic therapies, however, as I just showed you, really have not shown a surrogate effect. So These drugs like bevacizumab or VEGF trap or sunitinib did show a modest improvement in progression-free survival that was statistically significant, but no benefit in OS. And that could be for a range of reasons, such as toxicity, rebound growth during drug discontinuation, cross-resistance with other therapies. The fourth category of hormonal therapies, abiraterone, enzalutamide, and other emerging hormonal agents, there should be a strong impact on PSA. And so PSA may be a good surrogate and really needs to be validated in these phase 3 trials to see whether we can use PSA reliably to start and stop a patient on these active hormonal agents. And thus the message here is that the relationship of an endpoint to survival does depend on the mechanism. What about response? So PSA can go down and patients live longer. We published this in JCO 2007. So a 30% or greater PSA decline is associated with a better improvement in survival versus patients who do not obtain a greater than or equal to 30% decline. This has been probably the highest degree of surrogacy in the cytotoxic era. PSA normalization, probably a better prognostic finding, but not a great surrogate as it's not achieved in very many men. You can see that a drop in the PSA from the hundreds down to the 0 to 4 range happened in about 15 to 20% of patients with docetaxel. And if you achieve that, you've got a great survival, almost 3 years. But this didn't happen very often, meaning that it's probably not a great surrogate for trials. What about radiographic response? As you can see here, these are box plots for survival in the TAX-327 trial. And you can see really that patients who have a complete response or a partial response with docetaxel have almost a 3-year survival versus patients who progress right through with radiographic progression have about a 1-year survival. And stable disease is important, 23 months for patients with stable disease, indicating that radiographic scans, doing CAT scans, is helpful, particularly in patients with measurable disease. However, it's not a great surrogate because most men with castration-resistant disease do not have measurable disease. So why would a treatment improve progression-free survival but not improve survival? Well, this could be a statistical issue. You have a treatment effect that's very small. You don't have enough survival events. Maybe post-progression therapies reduce that event rate. We have certainly enough active therapies that that's a real possibility. It's also possible that statistical significance with PFS does not translate into real clinical significance and thus no improvement in survival. So if you improve PFS by a week and your p-value is highly significant, maybe that's not really all that important. Treatment-related mortality. So what if a drug improves your progression-free survival, but it actually leads to grade 5 lethal toxicity in patients where that risk outstrips the benefit? And so there are benefits to some and harms to others. That's a real possibility. There's also what I just described to you as measurement error. So if we're misclassifying progression, where actually it's response, we're going to get the opposite result and dilute our effect. But also important, many of these drugs promote cross-resistance to the others. We've seen a number of reports showing cross-resistance through some chart reviews of enzalutamide and abiraterone, and you'll see a number of emerging trials looking at that progression rates on that are related to cross-resistance, and this is due to altered tumor biology and adaptive mechanisms that promote cross-resistance through tumor evolution or clonal selection that make a patient resistant to both of these drugs, including other chemotherapies as well. Thus, we have a list of many different mechanisms of drugs, and the relationship of an endpoint, such as a surrogate to survival, does depend on the mechanism of action of the drug under evaluation. So to conclude, what's the preferred endpoint in phase 2 castration-resistant trials? Response or progression? And I'm not going to answer that because I don't know yet. And I would just say that it really depends on the mechanism of your drug. As I showed you, the mechanism is critically important. PSA declines may be very helpful when you're screening a hormonal drug. Bone scan changes, as long as you're using the working group 2 progression criteria where flare reactions are considered, are also important ways to screen for progression-free survival for many of our active agents, maybe not anti-angiogenic drugs though. Immunologic therapies, really don't result in bone scan responses, PSA therapies, at least our first generation immune therapies. And so maybe survival is a more important endpoint for screening in phase 2 trials of immunologic therapies. Resist responses are only useful if you have measurable disease, and typically that's less than 50% of men, particularly in the pre-Docetaxel setting. Many have proposed using reductions in bone biomarkers over time, but again, that would only be important if these biomarkers were elevated at baseline. And finally, I just want to talk about progression-free survival as well as circulating tumor cells. So those are also under evaluation for surrogates, but right now we just don't have enough data that's published linking the circulating tumor cell count or change across multiple trials and mechanisms as a surrogate. And that hopefully that data will be emerging over the next year or two. So to conclude, and I'm going to start taking questions in about 1 or 2 minutes, just to reiterate that prognostic factors, biomarkers, inform on natural history and have a role in treatment decision-making in terms of whether a patient has aggressive disease, symptomatic disease, visceral disease. All of these things are important in our NCCN guidelines and in our labels. For example, patients with who are candidates for CRPC are generally pain-free without visceral disease, while patients who are candidates for radium have no visceral disease and need to have symptomatic bone predominant disease. And these are prognostic biomarkers that can inform on natural history and treatment selection. However, predictive factors are really biomarkers that inform directly on a specific therapy. Current treatment selection algorithms really do not use blood-based biomarkers to really identify therapies, other than perhaps small cell prostate cancer, which really doesn't make a lot of PSA, and in which platinum agents are used commonly. But currently we do not use molecular biomarkers to guide therapies, and that is likely to be the wave of the future by interrogating androgen receptor biology, by looking at AR-independent prostate cancer oncogenes that may be important as we develop drugs that target these pathways. That is really the focus of future efforts, given numerous treatment options. And finally, surrogate biomarkers, they're very important for getting drugs approved. You have to understand that these biomarkers are mechanism and context dependent. It's very unlikely that a single biomarker will be a surrogate across all mechanisms of drugs. And for example, hormonal drugs, a hormonal biomarker such as PSA readout may be a reasonable surrogate. Circulating tumor cells may be a surrogate, but needs to be studied across many different positive trials. And essentially, we need qualification across multiple trials to address this topic of surrogacy. So in conclusion, if we can take these biomarkers and tailor our therapies such that perhaps we're defining RAF mutated prostate cancer, ERG overexpressed, or AR splice variant prostate cancer, or PTEN null prostate cancer, or tubulin mutated prostate cancer, we can tailor our therapies to these specific individuals who harbor these perhaps exploitable mutations. And we can get at these mutations from tumor biopsies, from circulating tumor DNA, from circulating tumor cell biomarkers. And ideally, in these subgroups, we would expect a greater impact on survival than empirically derived therapy. So I put here all the survival benefits that we've seen in kind of unselected patients. Hopefully, we can move to a 6 or 12-month improvement in survival with selected populations who are more likely to benefit. So with that, I'd like to thank you, and I'm going to start taking questions. And all right, so I have a first one from Victoria. She says, with the discovery and progression of new drugs, what is being done to preserve the drug in its original configuration from being made in a generic form, as some of the drugs you are using are being used in combination with other drugs to combat the cancer? And will those drugs be preserved as well due to the different fillers and binding properties of the generic drug? That's an important question. Certainly we're looking at some drugs already, like Docetaxel, going generic, and probably at least 10-15 years before abiraterone and enzalutamide go generic. Certain biologic agents may never go generic, such as Cipulis LT. It's really an autologous immunotherapy, and it's not clear that that could even be made into a generic. But I think it is important as we develop biosimilars, as generics come in, that The pharmacokinetics of these drugs are studied to make sure that we're not dealing with greater variability patient to patient. Using biomarkers to interrogate those trials as generics are being developed. It's really not enough just to show the same pharmacokinetic. I think showing a similar safety profile, showing some similar efficacy is also important for these generics, but I think it's an important question. So a second question is this a means to better avoid treatment? And so, yeah, I would say that I'm not talking about avoiding treatment here. These are men with really lethal prostate cancer. These are patients who have a 1 to 3 or 4 year survival. Most of these men will become symptomatic within a year if they're asymptomatic. And so it's really, the talk that I gave is really identifying patients to better sequence our therapies, not necessarily to avoid treatment entirely. Now, it's possible that if you have an asymptomatic patient with minimal disease burden and a very slowly progressive disease, I think you could reasonably say we could defer therapies, such as if we were to use Sapulous-LT or a clinical trial of a immunotherapy for a patient with low burden of disease. That patient could be safely observed, often for a long period of time without needing cytotoxic therapy or hormonal therapy. But I think the talk that I was giving is really identifying patients who would benefit the most from our therapies and would spare society and individuals the cost and harms of ineffective therapies. And we really need to move towards that as well. All right, here's a question from why aren't the studies not focusing much on drug metabolism given the reported adverse reactions? So I'll just give you an example of that. Abiraterone has focused greatly on drug metabolism, at least in the drug development of that. There is great patient-to-patient variability with that drug. There's a high food effect with that, and so the FDA label recommends taking abiraterone without food. Taking it with food actually increases the absorption 300 to 400%. And so there are some strategies looking at ways to take that drug with food that maybe would allow you to use less drug and save funds, or to take higher doses to overcome some of the other enzymes that abiraterone might inhibit, such as the 3-beta hydroxysteroid dehydrogenase enzyme. So, but I think you're right. I think there's a lot to be learned about even some of our commonly used drugs like docetaxel metabolism, how certain patient characteristics such as obesity, hormonal status, pharmacokinetics interact. And a number of the phase 3 trials are measuring these things. I didn't talk about pharmacokinetics a lot in this talk. That was a little beyond the scope. But these are important biomarkers in drug selection. Currently, we do not measure the PKs of any of these active drugs, which I agree is a problem, particularly if you have drugs that have high variability patient to patient. Okay, so I think we have completed our talk. I'd like to thank you for the attendance. Certainly, this will be available on the web for LabRoots, and I'd like to thank you. And I'm just highlighting here to obtain your CME credits. There's the link. And for those of you still on the line, this is the last slide. So this is the web page for the bioconferencelive.com CME link to obtain your CME for this talk.